What's driving national growth in all industries from one of the country's most dynamic regions?
Welcome to Strategic Compass, our new podcast exploring the strategic forces shaping the future of business. I'm Patrick Ryan, KPMG's National Managing Partner, Advisory Strategy and Markets.
And I'm Kathy Hollinger, CEO of the Greater Washington Partnership. We are thrilled to sit down with the region's most influential leaders to hear their stories of bold ideas, collaboration, and leadership shaping the economy from Baltimore through Washington, D.C., all the way to Richmond and nationally.
And as we dive into these conversations, we'll uncover how Greater Washington area CEOs are driving national conversations.
I'm Patrick Ryan, National Managing Partner of KPMG. Today, we're exploring how healthcare anchors are shaping the future of care in our region, not only through groundbreaking innovation, but also by investing in communities, expanding access, and building the workforce of tomorrow. Joining me are two extraordinary leaders. Thank you so much, gentlemen, whose organizations are at the center of this transformation. Dr. Stephen Jones, President and CEO of Inova Health System, and Ken Samet, President and CEO of MedStar Health. Thank you both for being here.
It's a pleasure. We're really glad to be with you.
Absolutely.
All right, so let's dive in. So before we get too deep into organizations and the great stories that we're going to talk about here today, I'd love to start with just your personal stories. Healthcare is a really special space, but it's also a really demanding field. And you've each devoted most of your professional careers to this area. So let's start with a few personal things. What first drew you to healthcare? Why you feel it's such an important field, not just professionally, but personally, and looking back, how early motivations have helped shape you be in the field. So Stephen, Dr. Jones, why don't we start with you?
Yeah, my journey is actually very atypical in that I grew up in a small town, actually only had one general practice doctor, not even a family practice, which is a specialty, but a general practice doctor. And the only interactions I had was when I needed stitches from all the things that happened on a farm. So unlike people who grew up around healthcare, I had really minimal. But I was good at science. I was relatively good at people. And so between my mom and a high school counselor suggested that I go into that profession. And so I ended up looking at a number of scientific areas, eventually settled on going to medical school, and eventually became a surgeon.
So it sounds like it was a pretty early life decision for you that it was clear from the earliest stages. Is that fair?
Well, really late high school and early college where it became clear in that if you're up on a farm, there's not a lot of routes out. You know, you can become a teacher or that was the most typical thing at that point. And so it was really a stretch for me to even consider going to medical school. And it turned out great. I couldn't imagine how rewarding it was, but I got a lot lucky and some good advice from both family and from teachers.
I think one of the key themes that I picked up on there too is care. In farming and rural communities, also just dealing with animals and livestock, that care element that I'm sure we're going to talk about more today. Thank you for sharing. Ken, how about you?
Well, if you were talking to my mother, she would love for me to have a story exactly like Dr. Jones because I'm the oldest and she actually expected her oldest to be a physician. So that's how it started. Unfortunately, when it was time for that biology class where, as Dr. Jones remembers, you get to pin the poor frog and then the pig and you have to do the incision. It was at that moment that I realized my mother's dreams were actually going to come to a crashing halt, and they did. And then it's just interesting how sometimes the stars align. At that time, I didn't know anything about hospital administration, healthcare administration, didn't know anything about healthcare other than we knew about doctors and nurses, and that's where you went for care, picking up on the theme that you and Dr. Jones already talked about. And I was a business major, a finance marketing major, and took an elective class in healthcare finance. I'd like to tell you a great story as I was already connecting things, but it was on a Monday night. You're not making this up. I'm going back a long time ago. And it was right before it ended, right before Monday Night Football would start. And so that was a great once a week class. It fit into my schedule. So I took it. And literally a hospital president in the local area and his CFO taught the class. And I'm sitting there in that first class, and all of a sudden they're talking about things that I actually do care about, you know, medicine, community, things of that. But it was all through the lens of how do you make the business ecosystem work for that. And it really was one of those moments. I talked to them after that class, and that opened up a whole different set for me. And I went to grad school and have a master's in health administration. And To this day, now my mom, I'm blessed she's here. My dad is, well, they're 94 and 90. So
Wow.
there's never a week that they're not in a hospital or seeing a physician. So I think now she's happy that her last name is Samet and I can help her get an appointment. But up until then, she was still thinking I could get into medical school.
So I guess maybe a couple themes for anybody who's younger out there is you guys have been very passionate about this for a long time, but two very different career paths. So something that I'm sure we'll spend some time today talking about. So shifting gears and talking a little bit about your organizations, both Inova and MedStar have deeply regional footprints that extend far beyond the hospitals. Your employers, innovators, educators, and community partners. As you think about truly being stakeholders in the community, Dr. Jones, how does Inova approach being that true stakeholder in this region?
I think in our industry, mission matters more than anything. So understanding what our role is, and it is as an employer. And I think Ken's comments made me think about the fact that when you're a kid, even if you grew up on a farm, you know about doctors and nurses, but you don't know about respiratory therapists or finance people or all the things that actually make that care happen. And so we probably will get into this a little bit later on the various pieces of all those things that have to make sure that the care is given. Our responsibility is to assure the health of our community. And so we know our geography. Our geographies are relatively adjacent to each other. We know what our focus is on providing that care. And I think unlike you see in some parts of the country where health systems, I think, are getting outside what they normally do, maybe because it's easier to go to something that you're not actually working on now than to try to go through the hard work of assuring the care of a community. I think one of the things that Ken and I absolutely agree on is that we made a commitment to the communities we have to assure that they have the health care that we need, not only the specialties, et cetera, but the geographic distribution as well. And I think that over the period of time we've known each other and worked together, we've assured that when you're in the Mid-Atlantic, you have the care that you need in essentially any of the geographies that we cover.
I guess I'm entering in a stage of life where I have little kids and parents that are getting older. All in this region, all have experienced both of your medical systems, as have I. I really have felt like over the last 10 years, especially, the inner workings for all parts of just the most newborn child to the oldest senior citizen has become a much more connected web. So maybe, Ken, on your shifting over to you, just how do you see MedStar's role in the local ecosystem?
So continuing to just add to Dr. Jones's comment, but really tying it a little bit to the broader ecosystem. So I've had the privilege now to be the CEO for coming up on 18 years. And if I go back to the beginning of that time frame, and maybe the 4 or 5 years before that as a COO. So, we're talking about the arc of a couple of decades plus. If I went to a big business meeting somewhere in the region, none of the real estate leaders in the region would come up and talk because I was the hospital guy. So you might need us when you're in that moment.
Yeah.
And if you think about how Inova and MedStar play throughout the region today, all of a sudden we went from, at the time, 7 hospitals, 10 hospitals for MedStar today to 400 sites of care. We became part of the engine that actually drives the region. We do that for care and strategic reasons that we'll talk about. But back to the ecosystem. Now, if I go to one of those business meetings, I've got 20 business cards from somebody because everybody's connected. Somebody has a building. Somebody wants to talk about MedStar in their community. So you start to really see that change. And I think some of that actually ties back to how our healthcare systems changing. And to Dr. Jones's point, if we're responsible for the health of a community, and again, when we started our careers administratively, we were responsible for the health of that patient in the 4 days that they were in our hospitals. It was not because we were trying to do something wrong back then. That's how medicine and healthcare in America was. If you were a hospital provider, you were responsible for those 4 days. But what we know today is most of healthcare happens outside of those 4 walls. And we can't just leave that to others because nobody's going to do what MedStar and Inova and our physicians, nurses, and others will do.
Yeah, the whole ecosystem has to work together to be able to make sure that the health of the community is strong.
Well, I'd just say we also need the broad ecosystem to be strong, because if you think about who is always going to be in the community, well, it's the hospitals that are inside Inova and MedStar and others certainly across the region. So we are inextricably linked to the communities, the vibrancy of the community. What's that broader ecosystem? And that brings in all kinds of players, including your organization and others.
I think, the ecosystem is so complicated. I'd like to continue going down that path, particularly as I think about this is really unique conversation that we've got two big CEOs sitting down at a table having a conversation at the same time. That might not happen in other different industries. I'd love to just talk about the connection that your two organizations have, how those work as an ecosystem. Obviously, you have different footprints across the region, but would love both your perspectives on how you work together and how that works from a medical community perspective.
So on the margin, do Inova and MedStar compete? Sure, but and these words are important, right? It's really on the margin, right? We not only have adjacent geography, but we have a shared responsibility for the health of the region. Neither one of our organizations, as special as they are, can do it by themselves. And we have to show leadership, because if we lead together, then I am hoping that businesses like yours, like other organizations, will influence government, legislators, regulators to help us in this really sacred mission. We can't do it by ourselves. So if you start with that premise and that focus on trying to do this together, and then it's one of the special things, and Dr. Jones will talk about this. When he did his medical training, there was some other physician that found a new way to do something really creative. In any other business, that might, if it's Google and Amazon fighting, they're not sharing the code for whatever they did. A physician goes right out at a big national meeting and says, let me tell you a new way to do this surgery. I think that's a really special thing, Stephen, about what happens in healthcare generally.
It is, and to the point, and in my own career as a surgeon, was fortunate enough to be able to identify new ways to take several approaches to treating, in my circumstance, cancer. And you're right. First thing I did was either get on a stage to let my colleagues know about it or to publish that work. And part of that is that ultimately everyone in the healthcare ecosystem wants people to be better. So if we thought that our competitors, MedStar, were providing bad care, we would want them to be providing good care. They would do the same to us. They would want us to be providing better care because they're our friends and neighbors. The other part that I think is unique, the need for healthcare in every community in America, including ours, is immense. So there's no way that any entity will ever meet the entirety of all the healthcare needs that are out there, which is sobering when you say that. But that's why it's so critical for us to assure that we have not only the hospital care. Ken mentioned the fact that we both expanded in hundreds of sites across the region. I don't even know the number of sites that we've got. If you do, I'm proud of you.
Well, I want you proud of me, but I don't have a number here right now. That's why I rounded, somewhere at 300 to 400.
Well, there's several hundred for both of us, because there's just so much need for healthcare in our community. And so no matter how much we're able to expand that, realistically, there will be more care that will be needed. And so I think that's one of the things that's different about ours. In other industries, it truly may be a fixed, you're going to take business away from competitor. At this point, there are plenty of days where, Ken and I may text each other or call and say, like, we're really just busier than anything. How are you guys doing? And usually the answer is, we're busier than anything as well. That's just the reality of
it's so special across this sector.
I'll give you an example playing off of that texting back and forth, which really does happen. And neither one of us could talk about the COVID times, right? There was a period in the first, half a year, 9 months of COVID. If anybody can just put themselves back there, it was a very scary time. And we know what was happening inside the hospitals. We know what was happening with people dying, staff dying. And so we're now in the most tenuous moment. And no matter what was going on, there was almost not a day that we didn't text each other with, have you all seen this? Have your doctor said that? Do you have a different approach to care? And if somebody came up with it, because back then we were trying to figure out what's a new way even to put a mask on or a vent? What do you do with a patient? If we figured it out, I didn't go to bed that night without saying to Dr. Jones, somebody said this at MedStar. Have you seen it? And that's a critical part. And by the way, in meetings then, I might say to a group of leaders at MedStar at that point, and did, I had a conversation with Dr. Jones, and Nova's trying this way. Right? I'm sure he did it. What do we think about that? Can we try that? I mean, if you're out in the public, you live in this community, you didn't know which hospital you were going to end up with if you are a physician, if you have COVID or any disease today. What you want to know is that collectively, we're bringing our best face forward. Nobody wants to hear, well, MedStar had an answer or Inova had an answer, and they kept it. That's actually not the organizations we've built.
That'd be the exact opposite of what anybody, I hope, in our entire industry would want. Certainly, I know Ken well enough to know we would have never wanted that.
Well, it's a mature concept, but I think perhaps in this sector, it makes it a little bit easier that the geographic lines are roughly drawn and you compete on the margins. But one of the important stories, I think, with healthcare is to tell that more broadly, that perhaps a little bit of the all boats will rise mentality could benefit some of the other sectors. Maybe that would mean that we would have different breakthroughs in technology and defense, education, if we did a little bit more collaboration. So it's exciting to hear that you guys are on a texting basis, on a daily basis, and that you're both committed to the same outcome.
But also, if you think about it, so that's from the standpoint of the community good, the mission, the purpose of the organizations. But it's also good business. I mean, we're sitting here now talking within this podcast. We're so connected and impacted by what happens at the local and state, federal levels in terms of regulation and legislation. And half of our revenue comes from some government aspect, between Medicare, Medicaid, and the rules and regs. We are so heavily regulated. So having them understand what some of their ideas might mean to those that actually have to provide it on the front line is really, really important. And oftentimes I find that, they'll think about the big defense companies or, the big accounting firms or the big law firms, and they forget how not only big these organizations are and important from an employer and other standpoint to the region, but we are the one group, as we've said before, that isn't leaving. And so we can't threaten. If you don't like what's happening in D.C., you say, I'll come to Tyson's Corner, I'll leave Virginia, go to Maryland. You do. This is our platform. So we're counting on, for long term, a conversation and an understanding about how decisions impact and then how partnerships can support us.
It's kind of our own version of install based.
Yeah.
These hospitals are not moving. We're actually replacing Inova Alexandria Hospital. It's decades old and not up to the care that's being given.
Where I was born, by the way.
Well,
Have you made a donation yet?
I have, yes.
Oh,
Right. I'm doing your job here, Dr. You should be asking that right away.
that was worth showing up for, Jeff.
Yeah, that's right.
Yeah. But the building was not up to the care that was is right now being delivered there. So, building 2 new buildings, those are going to be there for, probably a century if we've gotten it right. Ken's got hospitals that are, probably over 100 years old. So we are an anchor in the community. The other thing that I go back to one of the things Ken said, I think whether it be government regulators, certification bodies, anything, they hear the same thing from us. It's not like that, MedStar has a way that they want to approach the requirements to either be paid or just simply to practice. Same things we want. We want to be able to provide safe care. We want our team members to be safe, which is probably a topic that we should talk about. In fact, let me diverge. 3 out of 4 incidents of of workplace violence are in healthcare. The very people who are here to take care of you, 3 out of 4 incidents are of the people taking care of you. It's just a reality that we face every day. But I assure you that when either of us figures out a better way to protect our emergency departments or to protect our folks at any point in the journey, we're going to share those, because some of those folks, by the way, actually work in both places. Some of our doctors will overlap. Many of our nurses will work some shifts in both places. So our alignment on assuring that we take care of not only our business, but our people is actually pretty easy to just be aligned, because it is our reality.
It should be shocking to everybody listening to hear Dr. Jones's comment about workplace violence.
Yes.
If you think about that, you come in your moment of need, that whoever you're about to do something physical or verbal abuse to in a workplace harassment way, they're the only person standing between you and no one being there to take care of you. And they had to make a choice that day. They were sitting around their kitchen table, and he or she looks at their spouse or partner and friend and says, I'm going into work in that environment. If they ever thought that wasn't safe enough for them and they don't show up, it actually doesn't matter what title Dr. Jones or I have. I mean, those are the heroes on the front line. And it is sad to me after all these years that the statistic that Stephen talked about and what we're having to do to make sure we continue to create safe environments and that they feel protected is really hard for me to imagine that this is a top issue, but it is for hospitals across America, every geography. It was not that if I go back in time. I mean, you had certain moments in certain areas, but it is so different today. And maybe it's a sign of the times, but it's a shame that it's inside America's hospitals.
Particularly as I think about how far both of your organizations have come on the quality and availability of care. I wonder, though, if it links to the overall trend around what the workforce looks like. And you may be in a semi-unique space in that, we're not necessarily talking about offshore and a lot of, there is some level of technology and AI impact, but you're talking about people that are generally delivering care in person. What's the talent look like for you? You just mentioned that there's additional strain coming out of workplace safety. Has that been a positive development for you here locally and being a member of this community, or what other things can this community do, educators do, to be able to better support the medical systems?
Well, I'll start with, I think that we are in the people business and the trust business. Our only product is people. I mean, yeah, we got technology and buildings and stuff. Our product is the people who provide that care. It's a differentiator for us that we actually are fortunate on the planet we live on to have a bunch of people who are just really good people and who really want to make a difference in other people's lives. So if it weren't for the fact that the people who both of us employ really are just genuinely phenomenal human beings that are willing to put up with the challenges we both just talked about here, I wouldn't even want to be in the business. I'd have to go running and, to do something totally different. The fact that people are just good people and will put up with the workplace violence, put up with all the stresses, all the regulations and all, that is a differentiator for us that thank God we've got it. Otherwise, we probably wouldn't be able to stay in business. On the educator end, I think it's important. It goes back to when we were kids, we didn't know all the things that made a health system work. When I was in medical school, if you'd have told me like the hospital administrator, I would go, what is that? I'm just studying biology. I was okay with the frogs and things that Ken alluded to, but I didn't know that someone was behind it making all that stuff happen. Well, of course it did, but there are thousands of people that are making the things happen so that in your moment where you see a doctor or that nurse comes and comforts you, a whole bunch of people behind that made that happen. And not all of them want to be at the bedside. Not all of them are naturally attuned for those pieces, but they can make a difference by being part of the health system. Even if they're in finance and way away from anything and they're just even working virtually, they're making a difference by that work, because what happens at the bedside ultimately happens because of every single one of those people. That's a differentiator for us.
I'm sorry, I was just say if you stay on that theme. So, despite everything we've raised in terms of obstacles and worry, to Dr. Jones's comment, there are people that when they think about their life, they actually do want to take care and help. They wake up trying to figure that out. And I think we see that, and you see that with your young people that are coming into your organization. So thankfully, despite it all, there's something inside so many people that want to do that. And then if you, and every organization has to figure out how to channel their purpose statement. You do that for everyone that looks to you for leadership. But we certainly have an ability to both tell that story and they can live that story inside healthcare. And so then you get to, well, then how do they get prepared for the various roles that are there? And I think this is a very rich, broad region that creates those opportunities. Some folks are going to be really smart and interested like Dr. Jones, and they'll be physicians, surgeons, they'll go to nursing school and the like, they'll be a pharmacist. That's great. We have great education. Our long-term clinical and medical partner at Georgetown University. So proud to focus with the young people that want to come through for those jobs. But as Dr. Jones said, that's just one part of what makes healthcare work. So then what do we do to have other entry points? How do we take someone that's not going to go to medical school, not going to go to college, but can be trained for great jobs that are there inside hospitals and health system, tech jobs, perfusionist jobs, a couple of years of training after a high school degree, and they have a completely different career from an economic supporting their family, generational change than would happen if they, in the absence of that. And by the way, we have to have these people. So I think there's things we can all do, and we can talk about that if you'd like, for both our organizations, to help upskill our own people. And then think about what you and all the other, great companies are doing across this region. There's just a lot that can be done working with the universities, community colleges, to grow talent focused on applicable talent, as I like to think about it, for roles that are out there. I mean, between our two organizations, we probably have almost 60,000, people working in so many jobs. And between us, I don't know, I'm guessing it's 5,000 or 6,000 physicians only. So you can't be a health system without them. Yeah. But that's not the end of it. And most people aren't that. So
yeah, I think at KPMG, we continue to be really bullish on this region. It's, depending on which way you look at it, let's say it's one of the top 2 or 3 regions for us across the country. We love the fact that there's lots of great schools, people coming out of the schools, lots of really good people. There's a good public transportation system. The shift for us, though, has been in the last 2 to 3 years, the need for people coming out of school to really be of a different skill set, to really understand what technology means. And in your case, it sounds like be able to deal with evolving workplace safety and different changes in the organization. Is that something that you're regularly working with educators on to make sure that you've got the right skill set that's physically here to be able to serve your organization?
I think I've been around the country a lot. I know multiple geographies. I'll put our education system here with anyone.
Yeah, I agree.
The things that Ken mentioned, I'll tell you, the quality of nurses coming out of the nursing schools here is, if there's anybody in the country that's got it better, I'd be shocked. It's just hard. And I was pleasant surprised when I got to be here to see that level of nursing. The other thing that Ken alluded to is a career journey in healthcare actually can be different, I think, than other industries. And so if you look at that frontline person who may take a job in central supply, which is basically giving supplies or sterilizing things, okay, typically, doesn't require much formal education. But a lot of times those folks get in there, see the work that's happening somewhere else. They may get a job as a tech or a nurse practitioner, or go to medical school or become one of the hospital leaders. That happens uniquely in our environment, and working with those various, but not only the colleges, but the community colleges and the high schools to help prepare those folks for that journey. We've, I think, done a very good job in this community across the Baltimore to Richmond, of having not only the schools that do it, but the connections to the hospitals in ways that are differentiating in developing the talent pool that we need.
And think about that from the business model of the community colleges and the colleges themselves. We're having a discussion about healthcare and the value and the cost of healthcare. You got to have that same discussion about higher ed, of course, because the parallels are pretty significant. So one of the things that if you're a university or community college president, you have to talk about is, well, where do your students go when they get out?
Yeah.
Right. What's that job metric look like? And again, if you think about where the growth in hiring has been, healthcare is a significant part of that. So there's a natural match and a natural need for that to happen.
So it seems like the community really just works together. So that has validated my theory of why we need to be here, why you need to be here. As I think a little bit more towards the future, both of your organizations have had really groundbreaking approaches to some of the most terrible things plaguing the planet right now. Cancer, let's focus on that. Dr. Jones, your organization has really had a groundbreaking cancer platform. I can only envision that the people in your organization and the culture of innovation have been a big part of that. But can you share a little bit about what your organization's doing around cancer?
I think the big focus for us is that combination of the technology and the humanity, because a lot of places can get one or the other. What we're trying to do is to ensure that we have both. So, we've got everything on the technology end, from AI helping us to get more rapid reads, not only in cancer, but in stroke and some other areas, not replacing the doctor. I think, to be candid, I don't think it'll ever replace the doctor. I think there will always be a doctor in the loop. But in that circumstance, where spotting a stroke faster or spotting a cancer earlier, obviously there's huge value. And yes, those other MRIs will get read at some point. But the fact that you identify the one that's at risk so that patient knows it immediately, that's very meaningful. On the other, complete opposite end of it is, at the end of the day, it's just a person. It's a person who, they were in an MRI. They're a human being. They're scared. They have challenges that may become, very, very serious for them, obviously. So taking care of them as a person with the augment of the technology is the goal that we've set. And especially in our cancer center, I think that's where you're going to see it the most, but it goes across heart and all the various areas. Again, I know you've got a ton of that type stuff going on in your organization as well.
And I think Dr. Jones said it really well as he talked about combining, technology, latest advances, and people. And maybe the other piece I bring in, where he spent a lot of his early life as well, because of our Georgetown partnership, that brings in the Lombardi Cancer Center. So I think there's 48 or 50 of the Comprehensive Cancer Center designations from the NCI across the country. So it's bringing in a level of research. And for us, listen, there are some unbelievable research organizations, academic research organizations across the country. And I'm proud of what we do, but I think everybody has to tie that to how they deliver on that. And so for us, the ability to think about translational research, if something's taking place somewhere in a research lab, can we create one MedStar in a way that it connects to whatever's being developed, found? I'm not talking back all the way to the Petri dish. Again, that's a different level of research. And I hope one day there's a scientist that finds the cure for all cancer, as we all do, right? It's touched all of our families. But when we think about different approaches to care and different aspects of clinical research, can we bring that not just to the academic medical centers? Can we push that across every site? Because when Dr. Jones or I talk about the Inova health system or MedStar Health, in the eyes of a patient, for us, we talk about one MedStar in a way. And what that means is if you walk into an ambulatory site 45 miles from here down at St. Mary's County and you have a cancer diagnosis, you're not going to get the same level of every aspect of care there. We've got to get you back to the main places for certain things. But when you're having follow-up connectivity, front end, back end, is there a standard? Is there a connectivity? Are the physicians there connected inside the medical group to the physicians that are sitting at MedStar Georgetown and tied to Lombardi? And that's the work in progress that we've been on at MedStar. And I know Dr. Jones is at Inova because then you're bringing a different value for how we treat cancer. And cancer, again, I'm sitting next to a world-class expert. But the medicine happens, sure, it happens for a moment with that world-class, surgeon, doctor, medical oncologist in the main academic place. But the bulk of it doesn't.
Yeah, that care aspect is something that I'd love to get both your perspectives on. I think you guys have a virtual platform for oncology, and with my personal experience, I think just the logistics of providing care on a recurring basis. Obviously, the upfront diagnosis really matters, but I'd be curious, Ken, just how is technology helping you better connect with the customer, with the patient?
So I'm glad you asked it at the end that way, because I'm going to take a step from just cancer then in that, because I'm sitting next to a world-class expert. So if we're going to talk anything else about care and that, I'm deferring fully. And I'm really glad.
I'll save the juicy ones for him then.
Yeah.
Even though he's my friend, I don't give him a scalpel ever.
Yeah, no. No. It's interesting. I heard a line, and Dr. Jones made a comment that, it won't, technology, AI, it's not going to actually take the place. You'll always be a doctor. And now said as a patient, as a future patient. I sure hope so, because part of it needs to be people. But I saw a radiologist give a presentation once, and the question that he got asked from one of the board members was, well, how are you recruiting young folks out of medical school to be radiologists, because AI is going to replace them all? And he said, well, actually, that's not the way it's going to happen. What he said was that a radiologist that uses AI is going to be better than a radiologist that doesn't. But there'll always be a radiologist. They'll just be better using that technology. And I think that's what you were getting at relative to cancer care, heart care, whatever. So on cancer, that's kind of how I'd leave that.
Yeah, no, I'd love to talk about telehealth, because I think just as a patient, the thinking about the overwhelmingness of scheduling an appointment, going in for things that are non-critical, it really, I think, supports the health of our community so much better, being able to have these different platforms to access care.
So I'll make a quick comment on telehealth and I'll let Dr. Jones say it. And then we should come back to broader access, because it drives so much for sure. So telehealth is a great example of one of the really good things that happened out of COVID, right? It was out there before COVID, but even when I look at MedStar, small numbers, people understood it, didn't understand, whether that was from the care side or the patient side. The insurers didn't want to pay. Everybody saw it as an extra add-on. COVID happens, you have no choice, right? And it really blossoms. it became game changing. But what we also learned was it actually should be absolutely an integrated part of the overall care system, because there's a lot of touch points that can happen that somebody doesn't have to physically come in. You can utilize other connected care approaches. It's better care. It's interesting. I mentioned regulatory and legislative issues. It's a huge fight right now, and actually, we're in trouble with the government shutdown in terms of getting paid for that. But how do we turn around and then say to you as a patient, since you've already said you think it's so important, and now we would say to you, if we only cared about $1, we would have said to you, we're not going to do your telehealth visit anymore, because certainly, at least on the Medicare side, they're not covering it. We're still doing it, and I know Dr. Jones is, but I'm hoping when they reopen the government that somebody's going to take care of that piece. But that's how important I think it is for care.
Yeah, I think one of the things on the waiver, so far all the telehealth has been delivered on waiver. It's actually never been fully approved for governmental payers. And what we really need is permanent coverage of telehealth, because literally as we came up to the expiration, which was coterminous with the government shutdown, but actually not directly related to the government shutdown, but the waivers ended on that date. We literally are scrambling in the last few weeks of, well, hopefully we'll be able to have your appointment virtually, but we don't know. So that fact of going back and forth is really complex. The second thing that I don't think is evident, and I'll admit it was not evident to me, when we first started talking about virtual visits, it made sense that it would be less expensive to deliver that care than it would be in a building, because you have to have a building and pay for electricity and things. As it turns out, it probably is not a way to reduce the cost of care substantively, in that you still have the same people. You still have to get online. And of course, it's a little bit easier to walk in a room than it is to log on and make that interaction. So it didn't turn out to be the big cost savings that many of us, certainly me, believed it would be, but it did give the opportunity to connect people in places that don't have access. So, there are a lot of places in the country you don't have cancer specialists within 200 or 300, 400 miles of you. To be able to have that interaction is clearly valuable, especially for the follow-up. So for the right visit, it can be, I think, particularly helpful. It's unfortunately not probably the panacea to reduce costs as much as we thought, but even in our geography, just keeping people off the Beltway so that they're actually in their own home or office for that matter, as opposed to driving in, is clearly a benefit. But we do need permanent kind of approval, not just waivers, or it's never going to really fulfill its promise.
So I'm glad we talked about the regulators for a little bit. My personal view is that telehealth, at-home visits, the entire ability to meet the patient where they need to be is really important. As you see regulatory environment evolving over the next few years, like, where is this in 5 years? Do we have a full kind of government-backed support for the different ways that people really need care? Or is that something that still is a work in process?
I'm letting Ken take that one for sure.
So it's the best framing that either one of us would give you is your last word. Yeah, sure. It's a work in process. So that's the positive spin. It's also the negative piece of saying that if you think about where healthcare in America is over the course of decades, we don't have a connected, thoughtful healthcare policy. We don't have alignment of policy, regulation, how care gets delivered. What should the free marketplace, how does that work into this? How do these big nonprofits? We do not have a coherent healthcare policy in America. We haven't for the longest time. And there's so many aspects that we could talk about relative to that. What is clear is that 24/7, no matter what, America's hospitals are the last line. That's always open for everything. So, there are other, I won't do this by name, there are other big organizations that say they're going to be the core, the center of healthcare delivery in America, and they're creative and they're technology based, and they might have some sites as well all over the place. But let me know during COVID if they were actually there in the middle of it. Let me know on other moments what's happening. Let me know the breadth of the services they do, or are they more transactional for different kinds of care? Now, that is our problem. That's not society's problem. That's not the free marketplace is going to be the free marketplace. It's America. I get it. And some of that will push us to be better. And our competition, to your earlier question, I don't wake up at night thinking that, boy, it's all about Inova, MedStar, and if we just keep up with each other. I also think about all the other disruptive trends that are happening, because these other investors that are coming in, PE-backed firms and otherwise, startups around technology, it's not a bad thing. But without this coherent policy, people don't understand that if they're fully successful and we don't somehow continue to evolve and change and keep up and have certain reimbursement to pay for the things that only we'll do, you're going to take the few things that are profitable out of a hospital, put them out there in the free marketplace. On the one hand, that sounds good. And we're going to have all of America's hospitals left with the sickest, most intense care with Medicare and Medicaid not paying even cost. And it's a scenario for disaster for the long term. That's where not being able to have longer term discussion hurts. And so, I think that's a piece of what is a really good question, but a really complicated piece of healthcare in America.
It seems like there continues to be a divide on how quickly healthcare and your organizations are evolving on being able to provide the things that patients need to be as healthy as possible, with the regulatory environment keeping up with, are they funded? Are they allowable? Can we make sure that people have access to them on a reasonable economic basis? Am I reading that scenario correctly?
Yeah, I think so. I'd actually go back to what Ken was talking about. As a not-for-profit, we're both not-for-profit organizations. We have a responsibility to assure that ICU is available in the middle of the night, or the ED is in the middle of the night. Other entities don't have that responsibility. We will not ever, ever let that go. We will have the ED, we'll have the ICU. In addition, we have a responsibility for folks in our community who don't have resources to pay for their health care. So we both have tons of charity care around our geographies. At Inova, we've got over 30 what we call Inova Cares clinics, which are out there taking care of people who have no resources whatsoever. We literally give that care away because we know that those individuals have to have that care. Now, ultimately, we can only do that if we're strong enough to be able to do that. But that's one of the complexities when people look at, why don't you get simpler like other companies would be? Well, the answer is because they don't have an ICU, or they don't have free clinics for all the people who need it. As a not-for-profit, we both take that on, not, I guess, out of the goodness of our heart. We just would never consider that we wouldn't have that responsibility.
Part of serving
it's part of what we do.
Yeah.
It's an interesting piece too, because it's the nomenclature, when you think about not-for-profit, and which is absolutely what we are in the tax code and the like. And it gets confusing at times in the public light, because not-for-profit, we're also not the small sisters of the poor clinic that if you don't give your $100 donation, they can't stay open. There are a lot of organizations like that in this region. Thank goodness they are, and they're doing great things in food delivery and care delivery, and we try and work with them, right? So the difference is that as big as we are, and we're trying to make a few pennies on the dollar, we don't make it for shareholders and to move those dollars out. It's all reinvested in the community. We have volunteer boards who are community leaders that serve as the Inova board, the MedStar board. That's actually who Stephen and I report to. So they're representing so the dollars go back in, but like any sitting here at obviously one of the big four accounting firms, at the end of the day, it still has to add up, because when we make commitments, whether we're doing buildings or you expect your paycheck to work, or, we're buying goods and services, there's the reality of how healthcare has to get funded. And that is our responsibility. But back to the legislators and the regulators, it would be great to have more thoughtful discussion. And then one last comment, when you think about that at the highest level, and you think about H.R. 1, the one big, beautiful bill that happened, and I know that the leaders from healthcare organizations always would, that wasn't a healthcare bill, it was a tax bill. There were lots of other things going on, except buried in there, of course, are significant changes to Medicaid. Leave politics aside, wherever anyone believes, headlines aside, what is happening? Less funding and less coverage to people that are here getting sick. And what didn't change was that Dr. Jones' emergency rooms, MedStar's emergency rooms, hospitals' emergency rooms across the country, they're still open. And even if you were just fighting federal policy, there are federal laws telling us we can't turn people away in the emergency room. Now, by the way, we're not going to turn them away anyway. But if you're just thinking about federal policy, one federal regulation law now says people they're not getting coverage because of other immigration discussions they want to have. But there was no change on the other federal law that says, but America's hospitals are going to take care of them. It didn't say CVS would or Amazon would or anything like that. Again, we're going to take care of them. The economics of that, though, for America's hospitals are really significant in the discussion of how do we still take care of everybody else.
Are you guided by MedStar's position around community health philosophy and equity? Has that been something that's needed to change over the last couple of years with evolving regulation?
Well, it is not changing, and it'll be the last thing that happens, until the lights go out. I mean, that is the core of who we are as organizations, and I believe that for America's nonprofit hospitals, taxing hospitals across the country. That's why we were founded, and all the changes that you're seeing. Someone said, I remember my old when that little hospital was just standalone for that community before they were part of MedStar. But that's why that small community hospital, in the face of all of this, can still be the care delivery site for that local community. So the built-in, I love, after all these years being at MedStar, equity, taking care of all folks. We have 2 big urban areas we take care of, both Baltimore City. We have 3 hospitals there. We're the biggest provider of charity care and support in the district from a numbers standpoint, in addition to all else that we do. Take care of the Amish in St. Mary's County. We look and we take care, I hope, of people like you, Pat, that can pay their bill when they're done and help support this big ecosystem. And I still love that if we get it right at MedStar on this issue, then maybe there's some examples out there that we can get it right for healthcare across America, because we look like America. So relative to that, it's just super important, and it ties to all the discussions. And maybe I just bring in, one other issue on that. If you're 37,000 people at MedStar, people have their own beliefs on every issue. There's not a single issue where someone at MedStar doesn't believe, whichever side of an issue. That's okay. And I actually say to them, as I know Dr. Jones does, when I'm having big talks with at your kitchen table, God bless you. You think about it, you can do anything you want. And so can I, by the way. But when you walk into the door, whatever MedStar place you take care of, we're a team of people that have to come together to provide care. And by the way, we take care of anybody that walks in the door. So we have to make sure that moment, back to things that Stephen's talked about, that's got to be the moment where we have this sacred trust. We're not going to do anything to betray that in that moment. And then from an ecosystem standpoint, Stephen and myself, all the people that support it, we have to figure out then how to make that work. And that is a combination of everything we've talked about. It's philanthropy from grateful leaders and people across the regions. It's all of that to come together.
I think what Ken started with is that will never change. We're committed to everybody in our workforce and the folks that we take care of. I think you'll see that across the board within not-for-profit healthcare. We're there to take care of everybody. The challenges that Ken's alluded to are very real. Those are the challenges that we face in our industry.
So as I think about that community and some of the evolving trends, certainly I've witnessed a lot more focus on preventative care and wellness. The let's prepare for and let's be future facing versus let's just deal with the emergency that's going on now. Is that a trend that you're both seeing in your organizations, Dr. Jones? Is that
You do, although the irony, this struck me recently, that, when if you take your car in and the mechanic says, oh my gosh, you haven't changed your oil, you've taken terrible care of it, it's all rusted out. No one blames the mechanic for it not having well. We are indeed here, and most of what we do is to take care of people's health problems. These things that are often talked about, wellness and things, we just have to be cautious on what we mean by that. We can't make people exercise. We can recommend it. We can't make people eat right or not smoke or, harm themselves in all the ways that we all do. Not all of us, but most Americans will do that. And so we have to just be very cautious on, though, the hospital systems aren't going to be the solution for all of that. And it's interesting with the very well-known CEOs in town recently made the comment that, we have the worst health and health outcomes, of all the larger countries. So, well, no, we don't have the worst health outcomes. We have the best health outcomes. If you have a health issue and you get health care in America, either of our organizations, I assure you, your outcome will be second to none anywhere in the world. Now, the fact that we have health issues in our society, it's not that we're not fixing the health issues when they happen. It's that we actually have health issues that are now more than most other affluent countries. And so I think we just have to be careful and when we talk about wellness, what role should the hospitals and health systems do? There's a lot of it there, but we aren't going to fix the fact that society has all the other various issues. And I think they get conflated way too often.
I think the employers do have a role to play within that. You have an important role to play kind of more at the tail end. I do envision employers could potentially have a larger role to play more towards the front end. Ken, are you engaging with employers to help
Yes,
drive
and,
the
and
outcomes
to,
you want to
yes,
see.
and to agree with your comment. So, if you work for one of the big employers and that employer structures their health plans in certain ways, then absolutely you can create scenarios where you incentivize your associates to actually to live a better lifestyle, healthier lifestyle, and they get benefits from that, right? So that's really important. But if you think about the broad region, you have to segment the populations we're talking about. If you work at KPMG, you're one segment, right? You work for a big employer. That's one aspect of health benefits. You have Medicaid, you have Medicare, you have small employers, right? So they don't have the same approach. So as you move, when you ask the question and you think about it through the lens of KPMG, you clearly are thinking about some of the aspects that Dr. Jones talked about and the ways that creatively that can happen. I think there's a good connection back to your access question as I really think about it, because the aspect of preventive that Inova and MedStar are impacting today, and we're moving the definition a little. If we wait for you to come into our hospitals on whatever is happening out in the community on a care journey, you'll be sick, we'll take great care of you, that part's clear. But what could we do to prevent you from having to come into hospital around certain issues? They're not the same as wellness and working out in those issues. But if you're a young mom of color in Southeast Washington, the infant mortality and morbidity for decades is truly like third world countries. And I say that humbled and not happy. There was never a day. I spent a decade as the president of the Washington Hospital Center earlier in my career. There was never a day those nurses, doctors, care teams, Ken Samet, we came to do the best that we could for every mom of all colors, of all walks. And when they were in the hospital on that OB unit, that happened. It was the same care, interchangeable, except by then it was all prescriptive, right? Because there was no preventive care for those moms because they didn't do the things when they were pregnant to help assure a better outcome for them and their baby. This is a great example to your question then of partnership with business. With the support, $35 million grant from the Clark Foundation, we created a program called Safe Babies, Safe Moms, and it is focused on that issue: prenatal, postnatal, supportive care for moms of color in Southeast Washington. It's a coordinated program. Those dollars let us actually put community people in there, tied to research, tied to care. When they're ready to deliver, it's the same team that's delivering in the OB issue. And I just share with you because it's pretty actually staggering. I had somebody give me the numbers on this just to share impact we can have working. We wouldn't have done this program if we didn't have the support from the Clark Foundation. We just couldn't afford to do that. So I say that because it speaks to other possibilities, and it's not impacting your associates, but boy, it's impacting the total ecosystem. So far, this program, it's about 5 years, has touched 42,000 patients. 13,000 babies have been supported, and we've seen a 68% reduction in Black maternal mortality through this program. If you're in this program, that's the outcome difference than if you're not. I mean, and if you step back and starting with me, and you're like, wow, and you'd say, but if they've actually since added to their grant, because in all the other things we're talking about from a health policy and economic standpoint, I feel so good about this. And if there's no outside support, I don't actually know how to continue to support it. I want everyone to put their head around that and say, how can that be? Well, that tells you how complicated it is, but how impactful it can be when we work together. And that's preventive care. That's changing wellness, but I've changed the definition from the classic way that we might think about it.
And I would bet that a lot of the folks who are doing that work are not doctors and nurses.
No, they're not.
They're
Totally.
folks who understand their clientele.
100%.
And I think it's tempting often in science to, you heard 68% reduction. Well, that means some child who didn't grow up an orphan. That means a mom who was able to continue to be a productive mom in our society. That's what those numbers really play out to. And by the way, these are folks that may indeed be working at KPMG or any of our other employers too.
So we talked a little bit earlier about technology, and I can't, just in some of your remarks, Ken, it seemed like technology has a bigger role to play in preventative. You hit on AI and the impacts it may have across cancer specifically, but as I think about just significant increases in the amount of data that we can consume, I have wearables, look at the data, look at my sleep score. I have to envision that data is better able to inform broadly preventative medicine. Is that something that you're seeing, whether it's in cancer or just more broadly across preventative?
I think the jury's still out on that. I think there's been lots of data generated. Whether we've seen outcomes like Ken just described is not quite as clear. I can't tell you that within the data in healthcare, I think are twofold. One is in improving outcomes. There's no doubt that we can improve outcomes by being able to use big data, and that gets thrown around. But when we know that not only the data in Ken's organization, my organization, others are looking at how whether treatments are effective, whether certain diagnostic things actually do or don't improve outcomes, that's a place where data can really make a difference. For us, we've got really two buckets. We've got one, again, in imaging and some other areas where it's helping the doctor either get a more accurate decision or far more likely get a faster decision to the right people. You take an example of mammography. When a woman gets a mammogram and goes home and gets a letter in the mail, she will read one of two things. It's either normal or my children will be orphans, because anything other than normal just scares the bejesus out of them. Of course it would. It would for any of us. So if we can identify that mammogram that's not abnormal before she leaves and can get an answer before she leaves, think about not only the medical impact, just the human impact on that person. And we're getting real time with that right now. And not only that, I mentioned stroke and a couple of other places. The other place for us, AI is making a big difference is in a lot of our business processes. Some of the back office stuff, of course, this goes without saying, but things from scheduling for us, the ability for a physician to have an interaction with a patient that doesn't involve a keyboard is game changing, not just for the patient who likes the fact that the physician can look her in the eye, but for that physician who doesn't spend spend inordinate time doing all of that keyboarding and all, instead of either being able to take care of more patients or preferably be able to be home and get a workout in before they go to bed or have dinner with their family. That's where it's really, truly, our physicians use the term game changing routinely for that. And even in things like security, we are installing security cameras around the organization that are AI enabled, to the point on workplace violence a while ago, that can not only detect certain behaviors. So someone walking in with a weapon obviously goes without saying. Seeing agitation, which sometimes if you can figure out there's an agitated patient before it goes south, you can prevent something bad from happening. And unfortunately, Ken and I have more stories, I'm sure, on that than we want to share here today. But then also, is there a person in a blue suit and I happen to have a mixed tie on, that is believed to be a risk, that the AI in those systems can identify that person has just gone up to the third floor. The value of that, even way beyond the medical, is really happening right now.
Ken, maybe question for you is, I know at KPMG, one of the biggest areas of evolution, which is not medical, that we've seen is taking very disparate systems and very manual processes that exist. Sometimes today, I know that both of your organizations have moved forward in being able to streamline those more quickly, helping systems talk to each other. I see that from the business perspective. From an administrator perspective, does that make the hospital work better? Does it make it cheaper?
We have shown through my career that we'll buy the latest technology. Well, that's great, but we're not changing our underlying process at all. So you put new technology, great technology on the same process, you don't actually get the benefit of that new technology. What we did do now is have 17 different technology platforms, many of which don't interact very nicely. The cost of baseball just went way up, and we didn't actually get the productivity gains and whatever that efficiency gains that matter. I believe we've learned those lessons. We're learning those lessons. We are not done. But certainly, I'll only put this on MedStar. Maybe Dr. Jones figured this out at Inova a long time ago. But this issue of we're not buying big new technology or this technology, if you can't tell me how we're changing it, how not only how does it knit together from a technology platform, but what are you going to do different in this department or across a platform to make that happen? I do think, and I think Dr. Jones did a great job answering all the many different aspects that are happening. AI is really early, right? So there's some exciting pieces, there's some worried pieces, there's some bioethic, medical ethics issues. But it's going to be good long term. But the fundamental change is still going to have to happen for us to try and figure out how to use it. And it's classic, right? In America, something new out. We expect it all to be there today. And when all of a sudden we haven't changed in a day, we think, well, see, it's not as good. And really, no, I think it'll be so interesting to look back 10 years from now and say, wow, look how it actually got moved in. But underlying processes are really complicated. We are big, complex issues. You heard me mention one MedStar. Getting all of MedStar to be truly one MedStar through the eyes of the patient has been a career journey in this job. That is a work, and let alone a patient that says, well, yeah, I was in a MedStar place Monday. I was in a Inova place Tuesday. I was somewhere else Wednesday. And you all don't talk to each other. And for the patient, that's a big frustrating issue.
It is. But one thing we definitely do differently is we actually want the patients, when they're in your shop, we want the folks to have the information they need to take care of them, and vice versa. For one, that's just the right thing to do. Second of all, the last thing that we want is that patient to need to have more things done when we already can't meet all the demand out there anyway. So if they've had an MRI somewhere, we want that to be available, which in many industries be like, no, we don't want you to know the secret to our code. We have total alignment just because it makes sense for the work that we're doing.
Yeah. Well, let's try to bring all this together.
Well, I'd like to just jump in.
Sure.
Let's bring it together, because you're clearly not running a health system, because you said you're actually monitoring your sleep patterns. I would never look at my sleep patterns, and I know I'm speaking for Dr. Jones. That would really scare me, and I'm actually not going to do that. But perhaps you do, Dr. Jones.
You're telling me that their work is less
no, I'm saying than ours. I'm just saying, I know I'm failing that. I don't need a watch to tell me I'm failing on my sleep.
I'm trying to be preventative to make sure that I make the changes that I can control. And I think that's.
That ought to be really good on the pocket. The healthcare guy said, don't worry about your sleep. Yeah, I'm not the doctor. Remember, Dr. Jones didn't say that.
I won't tell you any of us doing this work are going to be sleeping like a baby.
Well, I mean, part of this is just, I think there have been times in my life where the general population felt like it's your job to make me healthy. And I have felt, I don't know if this is where I'm at in life, but I have felt that it's my job to keep me healthy. I know what your role is. I'm clear in what that is. Your ecosystems have massively evolved. The fact that I can, have a kid have something wrong, or especially during COVID, just be able to pop into urgent care that's a mile down the road from my house. I don't have to go through a complicated parking system and check in an appointment. And then if something big goes on, I have access to that. They have the same records. But all of that is still on me. It's on my children to be able to understand what is the state of my health. And I have more tools than have ever been available to do that. So I'm going to get off my soapbox in a separate. But I think we
would both be supportive of that. It does bring an interesting concept. Let's face it, 100 years ago, the average person lived 40 years? Well, now 40, you're just barely grown up, if you're not careful. So, what it means is that as we've gotten better at us preventing early death, hopefully most of us by doing things that actually help us to live longer. What it means is that we now, both of Ken's parents are in their 90s, and that means that we've got complex elderly patients who need a lot of care. So that's a big part of why the demands for our services are so great. We have a whole lot of people we're getting really good at keeping alive for a long time, and we want to do that. But it is complex to meet.
And those are different problems than what we dealt with 100 years ago, as you said.
Obviously, your approach, your attitude is completely right, and we would encourage everyone to have that view. You own your own health. There's so many decisions you make around that. For a lot of reasons, we know that isn't the case for all populations.
Yeah, of course.
And then when you just think about this issue of society, long-term arc, despite the gains, Dr. Jones's gains actually speak to what physicians and the advances in medicine are able to do on big diseases and traumatic care and keeping people alive at the end. And then in the face of that, there was a time in this country when it was one of the big fast food companies that had a whole campaign, and it said, supersize me, right? It wasn't enough that you could get a 20 ounce or a 30 ounce drink and a triple Big Mac. You could now go for 6. Supersize me. That was that. Yeah. And then we wondered why we had a whole cohort of young people that were 13 years old. They're pre-diabetic already. The die was already cast. They're going to have diabetes when they get older. That's going to go in the cost of healthcare. So back to some of those studies that Dr. Jones mentioned, when somebody, a business leader, an economist says, look at the cost of healthcare in America. That wasn't a hospital cost. That was a societal decision cost. We're on the receiving end of that. And there are other examples, not for today, societal decisions around certain aspects of how Americans can live their life. And when something bad happens from that, they end up in a hospital, we will save their life. The cost of healthcare looks like it went up, but actually we did heroic work in the most efficient, amazing way. But if you want to just get at the cost of that, make it go away. But those are other societal decisions. They're not health system decisions.
They have long-term implications. Well, before we wrap, I just want to say thank you to you both. Both your medical systems have been hugely influential to the health of my family, extended and otherwise. And some of them might not be here today without you. So it's there aren't a whole lot of CEOs that I'll be talking to that I'll be able to say the same heartfelt thanks. I really seriously mean that. Thank you for what your organizations do. It's been, and I speak for this whole community, that you are within the fabric of keeping us healthy. So thank you.
Thank you. That's why we do it. And I just say it is a privilege and a pleasure to get to do it with Dr. Jones and a friend and colleague who I respect immensely.
Couldn't put it any better. And I think we've done good things, and we'll continue to do many good things.
Well, this is special for this region. So we'll close it out with one question. We're here talking about the DC region, great businesses, great leaders. Dr. Jones, if you had to place one big, bold bet on the future of healthcare in this region, what would it be?
I think that you will see us focus on doing what we do and aligning with the other folks who do other things better. Ken's already talked about one of those. For us, supporting community organizations that do work that's complementary to us in healthcare has allowed us to focus on the healthcare. I think the second big piece will be technology will indeed transform the way we deliver care, but not necessarily in the magical Jetsons way, in allowing human beings to be able to focus on the other human being, because the technology will do as much of the other work for them. I think that's going to be the biggest differentiator, and both of us making the commitment, as hard as you just heard it is, to get the technology in place to allow us to be humans, because I go back to something I said earlier. At the end of the day, we're just in the people business.
Yeah. Ken? Same question to you.
Well, no real surprise. We could have answered for each other. So I think that just as Stephen just said, I think the big bet for MedStar is exactly what we're doing. We are making, again, I speak for another, we're making multi-billion-dollar investments to be better versions of exactly who we are and who we've been for more than a century, to make sure that we are deeply embedded in providing care in ways that it's contemporary, that touches all the issues around equity, community, partnership, using technology to do. That is the big, bold bet. And when others threaten all kinds of things in terms of what region they're committed to, what's a better platform for their business, which, by the way, they're entitled to. Those leaders get paid to do what they have to do for their organization. Somebody needs to be saying that Inova and MedStar are incredible organizations 5 decades from now. And if that's true, they'll be using at least some of the big, bold bet that we made now.
And I think really important for this region is the fact that when you're an employer, you want to know that you've got the right education and the right health care. A lot of other things go into it. But without those, as an employer, you should probably consider being somewhere else. So our commitment to making sure that employers have access to that care here is, I believe, a differentiator for our region.
So we're all aligned. Well, gentlemen, it's been an absolute pleasure. I look forward to talking soon.
Thanks for having us.
Thank you.
Thank you.
Thanks for tuning in to Strategic Compass. We hope you'll join us next time as we continue our conversations with the Greater Washington area CEOs shaping the future from Baltimore through Washington, D.C. to Richmond and nationally.
Subscribe to Strategic Compass today and follow us for more insights from the corridor's most influential leaders, helping you stay informed and inspired.